Hello and welcome to Health and Wellbeing Live in Nottingham City. This is your periodic exploration of the people, services, issues that matter to the health and wellbeing of people in Nottingham City. Today we're talking to Steve White, who is Digital Transformation Manager at Bestwood and Sherwood Primary Care Network, and we'll be talking about community engagement and a little bit about health inequalities as well. So welcome, Steve. Hello.
Hello.
Good. So, do you want to introduce yourself and your role, Steve?
Yeah. So, as you said, my name's Steve White. I'm the Digital and Business Transformation Manager for the Bestwood and Sherwood Primary Care Network, which is probably the longest title ever. But what that involves is a lot of community engagement, a lot of managing of the network, and a lot of the services that the network run, including the ARRS teams, clinical and non-clinical, across the area. So that involves managing teams of pharmacists, physician associates, and nurse associate, health and wellbeing coaches. We haven't got any more of them, but we did have health and wellbeing coaches, care coordinators, social prescribers, and some external services as well. So, yeah, quite a lot involved in terms of the variety of the role, which is good.
Yeah, and it's a big and busy and complex job, and I suppose that the part of that we're going to focus on today is around some of the good work you've done in your primary care network around community engagement and tackling health inequalities. And we'll probably mention a little bit later, but I gather you've garnered some awards and recognition for some of that work as well. So we'll talk about that, I guess, at the appropriate time. But First of all, Steve, it's nice to ask people, so why are you here, or how did you get here?
Sort of just over 20 years ago, I started working in the further education sector, supporting really people who hadn't sort of excelled at school, at the sort of the lower end of the economic scale of society, to support them into finding work and educating them and getting them sort of basic maths and English skills to be able to build a career, and dealing with sort of, long-term worklessness and a lot of the people that you see within practices with these long-term health conditions. So we had specific programs for people, for example, with criminal backgrounds, people with disabilities, people that just come from deprived backgrounds and sort of long-term unemployment and worklessness and intergenerational worklessness as well. So I had a long career in that. Worked my way up to National Operations Manager for one of the largest college groups in the country. Worked all over the UK, based in London, Glasgow, Manchester, Sheffield, and Newcastle predominantly, and Nottingham. And then I had a road accident in 2018, which was quite a severe one. So much to the point where I had to miss one of my marathons. But I had to sort of sort of look at my career, really, because I couldn't do the things that I could do sort of physically and mentally. So I went to work for the police for a couple of years across in Lincolnshire, using my learning and development skills to work in learning and development for the police. And then I did that for the best part of 3 years, and then came across to work for the training hub over in Nottinghamshire, working with primary care to support things like apprenticeships. Had real success there. And then this role came up. And it was really a really appealing role, because I was looking at it and there was a lot of talk around health inequalities and supporting people. That really helped throughout my career. But why that was really important to me was because, where I'm from an area, I live in Newark, and I've always lived in Newark. I'm from Newark, and it's got Newark. People see it's quite an affluent area, and they see it as quite a nice little sort of quaint market town. But it's got the highest sort of social mobility gap within the UK. And I come from one of the deprived areas in Newark, and the appeal to the role really was for me to have the opportunity to make a difference to people that are from the community that I'm from. So the patients that we have, particularly these that are experiencing health inequalities, that could be my mum and dad, it could be my brother, it could be my friends from school. So that's something that I was always really passionate about. I used to given my local council as an MP an absolute nightmare when I was sort of talking about health inequalities, because I'd sort of picked up on these things as my career progressed. So this gave me the opportunity, I think, to use the skills that I've got, particularly in that leadership forum, to make a direct impact really and support that sort of health inequalities reduction across an area that that I was semi-familiar with, but demographically was very similar to where I come from. So these were the people that it could be me and my family. So that was what was really important.
Yeah, it's really I find it's really interesting how the health equity and health inequalities agenda, it does actually draw people in. It can be a tool for recruitment, as it has been for you as well, to stress the impact that people can make in those areas in this sort of work and this type of job. So it's really interesting to hear.
I think so. I think because I didn't particularly get caught up in the whole the NHS thing with COVID, because I was working for the police and we got a lot of the same sort of kudos, if you like, being a service that still continued. But we're all impacted by health. Personally, family wise, we've all got people that have been reliant on primary and secondary care, and we will be, and we're users of it as well. So to be able to influence and support the initiatives that are taking place, it's quite valuable and rewarding. A lot more than some of the commercial roles that I've had. So yeah, it's a real catch.
That's really good to hear. It's good. You're obviously drawn to this work and find it rewarding, and people out there might work in other areas and other roles and be attracted to this sort of work as well. So that's really
Absolutely.
positive. And it's one of the big tragedies, I think, of Nottingham, and probably many ICBs and places around the country. But just the health inequality and the difference between the health outcomes of those people in the most affluent categories of society compared to the least. I think it's about 10 years. I think the healthy life expectancy difference between someone, say in Rushcliffe, south of the River Trent, and just go a few meters north of the River Trent into the Meadows, for example, and the healthy life expectancy is far worse. But I suppose it's also an opportunity, isn't it, Steve? Because there is a gap there that you can close. It is possible for people to live healthier and live longer and healthier lives. But
absolutely, and that was a thing for me, because so sort of rewind 10 years ago. So I was 25 stone. I was pre-diabetic, high blood pressure. I thought I was fit, but I wasn't fit at all. And I had a bit of an awareness of my own health, a bit of a rude awakening, really. When it come to it, I had a very lucky escape. There was nothing wrong with me, but it gave me enough to sort of look at health and look at my health and look at my inequalities and focus more on diet and exercise. And it gave me the opportunity to do these things, and everyone knew me as the 25 stone guy, and this was within my career, within my social circles and everything else. And then eventually I started running, became a marathon runner, Ironman, all that sort of stuff, and that impacted on people within my local community, because they saw this overweight guy who could do it. I was like, how do I do that? So I've got quite a few people now that are involved in that and do a bit of coaching outside of work. But it just, people didn't know it was accessible to them. Going to a park run on a Saturday morning, for example, is open to everybody. It's not just an upper class or a middle class thing. It's not particularly expensive. Depends on the amount of races that you book and where they are. It can become expensive, but there are certain things and initiatives that are accessible to people across the economic scale that people just don't understand are available to them.
Yeah, you're right, Stephen. Sometimes it is about role models. It is about socializing and demonstrating that these behaviors are possible, that people, from similar backgrounds do and can adopt these healthy behaviors. So, Steve, I'm going to move on to talk about some of the stuff that you've been doing in the primary care network in Bestwood and Sherwood. And I wonder if you can explain a little bit about maybe some of the things that you've achieved around community engagement and health inequalities, and then maybe we'll have a discussion about how you've achieved that.
I'd say the crowning achievement of the past sort of 12 to 18 months has been our community hub. So we have a health and wellbeing community hub that happens every quarter, and And what that is, it's something I inherited. So I didn't reinvent the wheel on this one. It's I can't take full credit for the concept of the community hub, and they are a national rollout. But we had a hub, and it was a social gathering. People used to come to us, particularly those on the sort of, again, the lower end of the economic scale. They used to come and get food vouchers from us. We used to have a clothing bank and hygiene bank, that sort of thing. And what we did, so I looked at that, and we were getting about 30, 35 attendees per hub. And we looked at that, we thought, we could get so much more. We've got such a catchment area. We was holding in a prominent area within Bestwood and Sherwood. And what we did, we turned it into a little bit of a more of a medical intervention. So we started sort of moving away from the gizzits, if you like, and the gadgets that were there. But we brought in a lot more community partners, and we brought in the whole of the ARRS team. So we had pharmacists there, physician associates there, nurse associates there. We had social prescribers there. I mean, the social prescribers were always there, but they had more of a sort of a role within there. So we get patients would come in. We'd take their blood pressure, we'd do their height and weight, we'd be checking them. We'd have pharmacists that were there that could give advice, health and wellbeing coaches that could give them sort of lifestyle advice and support, and we could build caseloads of patients, really taking them away from the practice. And a lot of these people wouldn't come into practice. It was just a community event that they went to see what was there, and it really worked for us. I think probably the biggest success story, one of the biggest success stories we had. We had a gentleman from the local community, and we hold the event in the Indian Community Centre on Hucknall Road. And without plugging them, but they do fantastic curries at lunchtime. And a lot of the local workers, they'll go there to buy their Friday afternoon. That's their Friday afternoon treat, and they'll get a curry. So one gentleman from a local factory, he came in to get his curry. Poked his head around the corner to see what was happening. Oh, I didn't know this was going off. Sort of got caught up in the moment. So he had his height and weight that was taken, and his blood pressure taken, and he was significantly he was displaying high blood pressure quite significantly. So at that point, he went through a process with us. Within a week, he was with a GP. Medicated for that blood pressure. He would have never known he had high blood pressure at that point. And then it was being managed. He would have never, there'd have probably been an incident or an event that would have taken place if he hadn't turned up on that day. So, the fact that we have so many community partners there to be able to support that type of journey means it's a little bit more involved now, and we get real outcomes from there.
Yeah, so it sounds like you took something that started as more of a kind of social sort of activity, and then medicalized it a little
Absolutely.
bit, and more medical relevance, which I think is really interesting. And I was just wondering, so when that patient went to their GP, what kind of relationship or involvement do you have with the GP practices? Because sometimes when you talk to GPs, they'll be sort of a little bit critical, or say, "Oh, why is this person turning up having their blood pressure done in the community? I don't know anything about this. What shall we do with them?" Or at least the receptionist might react in that way on a busy day. Have you built those bridges with the GP surgery so people land well when they come from?
Absolutely. So the GP surgeries, they know exactly what we're doing. So they know when the hubs are, they know what we're doing with the hubs. We keep them informed. We have sort of monthly board meetings where we talk about these initiatives. And in addition to that, I have a meeting with the practice managers as well. So we just discuss operational things and initiatives that are taking place going forward. So people are clued in. We have sort of like circulars, emails, good news stories, and newsletters that go to the practices. So they're fully aware. We involve the patient participation groups as well. So that that patient voice is there as part of the hub. So everybody understands what happens at the hub, and we do that. Luckily, in that sense, the GP in question was also our clinical director at Bestwood.
Oh, right. All about
that's how we found out about the the sort of follow up of there. But it just gives us, the fact that we have such a close relationship with our practices, and we have that sort of constant communication, it just makes it a lot easier to land these things, and B, to make sure that we're all singing from the same hymn sheet. So we contact the patients for the practice on behalf of the practice to invite them to the hubs in the first place. Excuse me. So there is that sort of constant, ongoing communication between all parties.
I was going to ask actually, Steve, if you do any targeting in terms of the people that you invite to or market the hub activities to, or are you doing any particular targeting or cohorts?
It depends. It depends. So we have the big hub, which is pretty much it's advertised to everybody, and it's not just we'll send messages from the practices, but we'll have sort of social media campaigns and so on and so forth around there. But sometimes we'll have mini hubs that are targeted. So it might so one thing that we have is a cardiovascular disease hub that happens once a month, slightly different to the main hub, and that's just aimed at patients that are at risk of cardiovascular disease or have got a diagnosis. We've had sort of women's health hubs. We've had sort of things like cancer screening hubs as well. So it depends on the nature of the activity that's going to take place. And if we know we've got a certain provider that's going to be attending there, we might target through the various systems certain patients to say, if you come here, you can get this type of intervention.
So Steve, you mentioned certain providers. So does it kind of change who's there? Do you have kind of special guest providers? How does that work?
Absolutely. So we have sort of key themes that are prevalent within the PCN. So you'll always see support for cancer there. You will always see an element of support for CBD. You'll always see health and well-being. Usually you will see COPD as well. So sort of and diabetes. So prevalent conditions within the PCN. There will always be a presence, and then we'll rotate it, and we'll talk to the patients that attend the hub and find out what they want as well. So I think it's about 3 hubs ago now. We was getting a lot. There's these big campaigns around breast cancer and cervical cancer and so on and so forth. But a lot of the elder gentlemen that were attending the hub, they were saying, I ought to go and get bowel cancer screened, but I don't really fancy it. And testicular cancer, and you see all these campaigns for women's cancer, but you don't really see a lot for men's cancer. So we invited some community groups that were involved with men's cancer as well, and that went down really well. So that was listening to the patient voice, finding out what they wanted to see at the hub, and inviting them in. Obviously we can't always invite everybody in, but if there's a groundswell for a certain type of service, then we'll bring them in.
Yeah. And Steve, how do you kind of tell everyone about it? Because I'm sat here as a GP and I'm thinking, actually, if I knew that at a particular time each quarter, each month, however often it was, that all of those services that you mentioned were together, I think, actually, I might be able to actually just signpost people and tell them about it, or give them a flyer if they need some cancer support. And you could go along to the hub, or whatever it is. What's your kind of communication strategy around it?
Yeah, sure. So there's an ongoing dialogue with practices, and there's posters, and there's the email circulars and all that sort of thing. And obviously, we do send messaging, text messaging out to patients to let them know that's happening there. Also, there's a lot of word of mouth. So one thing that I've got from my previous history is quite a lot of marketing experience. So what we'll do is we'll build a campaign. So there's a social media campaign. So you see it advertised on Facebook, LinkedIn, Twitter, all these. It's not Twitter anymore, it's X. But all these social media platforms. So that the local, and these are all targeted at the local community. So they'll be involved in there. Also, the community partners that we've got. So these various partners that do attend the hub, some that don't. But even those that don't, they're aware of it. So they can, sometimes they'll just turn up as a presence, and they'll support that campaign, and they'll market it to their clients of whatever service they're providing. You've got the attendees themselves, and they'll be marketing it and telling people that they're there. So you've got the social media campaigns, and again, they'll be telling their service users that they've got it as well. We have quite a bit of ICB involvement, and they'll be promoting it as well to the local community and beyond. So yeah, we try and engage as many people as possible, tell them about it, and we've got, because it's been such a successful hub. There's a lot of the word of mouth now, so people understand. So someone will tell someone else, or they'll bring someone else with them. So in terms of numbers, we started off with about 30 odd. Now we see in excess of 200 people per hub.
Wow.
And they're all coming. Yeah, and they're all coming, and they're all coming for an intervention, as opposed, we don't give away the vouchers anymore or anything like that.
That's really impressive. And it actually sounds quite reproducible as well in other primary care networks up and down the county, up and down the country. I'm sure people are doing similar things. But
absolutely, there's successful hubs in other areas. There's some that are more frequent. There's some that are smaller. I don't think there's anyone's got a larger one. But it's a concept that can be used, and if you get the right people around the table, the value of it is phenomenal.
Steve, I was just wondering, I'm going to ask you 2 more questions about this, and then we'll maybe quickly touch base on some of the other things that you've done that have been really successful, and get some of the key kind of learning or tips from you about those things. But I was just wondering, particularly with the hubs, what's the kind of secret of your success? Because 200 is a lot of people coming to them. So I think that's probably more success than some other places would get. How have you been able to achieve that as a primary care network?
I think it's finding out what the real need is. So understanding the community is really important. So I could have ideas around what I want to see at the hub, and I can think that's absolutely fantastic. But unless it resonates with the community, it's not going to land. They don't care. If I start pushing, we work with the football teams. So if I start pushing, here's a initiative that's being run by Notts County, but the local area don't want to engage with that, the population don't want to engage with that, then there's no point doing that. So it's understanding what they need, and again, it's understanding what the local partners, including the practices, want as well from it. Yeah. So to get that engagement, what is in it for the practices? Well, we're seeing people on their behalf, where sometimes we're jumping queues for patients, because they're seeing a clinician on the day, which sometimes to get an appointment, it doesn't happen, particularly in the larger practices. So that works. So and once that goodwill and that reputation builds within the community, it gets larger and larger, and then to the point where sometimes we're trying to, at the end of the hub, we're trying to look, is there anyone else coming, and people are still coming through the doors when we should have closed. So it builds real success, but by talking to everybody who's involved, all those stakeholders, including the community, that's where you'll get your real benefits.
Yeah, listening, it's such a simple tip, but it is really, really tempting when you're a clinician or not a clinician to sort of think that what the community might need, or what people are pressurizing you to do is what you should include in these hubs, but that's not necessarily what the community or the people want, is it? So
absolutely,
really good learning. Absolutely. Any major challenges? What's maybe been your biggest challenge, would you say, Steve, and what have you done about that?
The initial changing of the hub. So the hub, it had been established for probably 6 months before I got there. There was real challenge because people came for the vouchers. That's what they came for, to get this free stuff. So to move that away was a real risk, and people didn't think it was going to work. But it did. So that was a real challenge. So it's changing those mindsets of this is what it is, and this is what it's going to be going forward.
It sounds like you just held your nerve and did it, really, in the face of that.
It was, and sort
challenge
of
people,
finding key people within the team and within the practices as well, to sort of champion the idea of where we wanted it to go. That was a real challenge, and also sort of engaging with some of the partners. That can be tricky, because they're really busy, these organisations, and they've got limited funding. And do I go to that event or that event? So to sort of sell the concept of, if you come here, you're gonna see X amount of people, especially before X amount of people turn up. Now the first the first one that was in the new world, if you like, I think we saw 50, and then we saw it doubled very quickly. I think it went to 120. And then that sort of built its momentum. But to sell that concept of we're going to start seeing a lot more people, even though we're going to completely change it and we've got nothing to gauge it against, was quite a hard sell. But they supported us in turn to do that.
You make a good point about achieving a critical mass as well, because once something is seen as successful, it draws in other partners, doesn't it? And it draws in other people. So that's really important. Steve, I'm going to ask you some really quick fire tips on some of the other things which I know that you've done. So digital inclusion, what are your top tips for improving digital inclusion?
Look at what the digital inclusion agenda is, and really look closely at your patient base and look at why they're excluded.
Okay.
Is it accessibility? Is it education? Is it a combination of the two? And then look at A, if there's anything locally that you can do about it, or B, if there's not, what have you got within your team to do something about that? We've created a digital inclusion training package for patients that's been piloted now, which is the first one in the country as far as I'm aware. But that's really, really huge. And I think the way that the digital world is moving, and particularly the way that health is moving onto all these digital platforms, the people that are furthest away from in those health inequality bandings are going to move even further away if we don't address it immediately.
Wow, that's really, really impressive. So what does that training package look like? Is that delivered live? Is that
it's delivered live through social prescribers and care coordinators. Yep. So luckily I used my educational background, so I wrote a package for the PCN with our patients in mind. And we look at things like, the NHS app, which government announcements was that's going to become, a lot more functional going forward. So, but making people aware of the app, getting everyone signed up for the app, showing them the app. Modern general practice, what does that mean? NHS digital account, what does that mean? I can access my records. I can order my prescriptions. We were having people, they didn't have smartphones. The patients that were coming to us, a lot of them that we piloted with. One of them had it looked like a Nokia 3210, but I think it was a cheaper version of a Nokia 30. Can I get the app on this? So these are the levels that we're talking about. People are fearful, so we talked them through how to get the documents online, how to get the documents. We talked to them about phishing and scams. We also introduced them to things like Google Maps, so that you get an appointment at the hospital. I've never been to the hospital before, or I've got to go somewhere else within the community to a community group for the social prescribers. We've showed them how to use Google Maps. We've showed them WhatsApp as well. So they created a support group within the group, and some of these people are socially isolated as well. So it just encompasses so many things, and it talks to them about you don't need to ring at 8 o'clock in the morning to get an appointment. You can go online. So all of these initiatives that are there to support general practice, most people don't know about them, and they don't really care about them until they're identified, and then they think, well, actually, that solves a big problem in my life. So yeah, that was huge. We piloted it in one practice. The next practice that goes live goes tomorrow, and we're piloting it in a community setting as well at the moment. So it's working really well.
Ask you about something else now. When we were preparing, you mentioned data driven. So what do you mean by that, and what have you been doing to be more data driven, or what does data mean for your PCN?
Yeah, so what we do, we use things like HealthScope and various other sort of digital platforms to look at where are the shortfalls within the PCN, and where do we do really well? So and by looking there, and even on practice level, say, look, this practice is struggling with I don't know, childhood immunizations. It means that we can sort of flex some of our teams, the ARRS teams, to support those practices into bringing their performance up in those sort of key areas. So we'll use that and a campaign. So at the moment, right now, actually, it was launched last week. So we're supporting practices across the PCN with blood pressure to meet blood pressure targets. So care coordinators are they've done that sort of data drive, identified the patients. They're working with the practices now to contact those patients to get those blood pressure readings for them. So that shows a direct impact. And again, we've done similar things with sort of cancer screening, with immunizations, with you name it. So it really is that sort of PCN collaborative feel where we can make a direct impact on what happens within the practice.
Yeah, that's really interesting actually, because I think many of us are getting used to looking at the data and the various data sources that we can get this from, but there's often that conversation then about, well, what next and what can we do with this? So it's good that you've got that ability and that agreement to flex some of your primary care network resources to reflect the data, and where that need is. And it might not be equally distributed, I guess, across all your practices, which means, maybe not everybody gets all their share of that, but from a patient perspective, it means a better use of resources, doesn't it?
Yeah, and some practices, they don't need that support. Some practices, they're on top of it, or they've got a plan in place, and they've got the right resource to be able to do that, and maybe got real expertise in that area. If you look at like SMD, for example, they may have real specialists within their own practice, but some practices won't, and that could be for a multitude of reasons. It could be just general resource. Sometimes the smaller practices just haven't got the time to be able to do it. So the fact that we can sort of flex that resource, and we do that in conjunction with the practice as opposed to separately. We have that conversation. Is there anything you want us to support with? We're doing it with dementia reviews at the moment as well. So social prescribers involved with supporting practices with dementia reviews. So to take on that sort of social aspect of it, and then the referral will probably come through that way. So it really is that sort of partnership collaboration.
Good. We've got a lot more planned to talk about, and I'm tempted, Steve, to invite you back for a take two at some stage, rather than those in a superficial fashion, because I think there's been a lot of real gold in there, really, in terms of tips for other primary care networks or other parts of the system. Last question that we ask everybody is, so what next? So people have maybe spent the time watching this to the end and are listening to us now. What would you like them to do next? Sometimes people say look at a website or something like that, but sometimes more interesting stuff. What should people do now?
For me, it's have those conversations. Go out there, see what's in the community and see what's not in the community. Understand that. Look at your data. Find what is your data, and understand your data. What is it telling you about the population? Where are those gaps? Where is that support required? And is that something that you need to fill with local partners, or is that something that you need to do with your own teams? And see, to do everything you can really to get that support in place to make sure that you're getting those patients the care that they need.
So, Steve, I'm going to thank you very much for giving up your time to speak to everybody. Thanks everybody for listening, and thanks Tim, who's been monitoring, and we'll edit this and get this out as well. Thanks very much, and maybe we will have a take two.
Absolutely. Thank you.